Okay, so we're going to start talking about brain injury and axonal injury and how do we recover from that and the effects of rehabilitation on plasticity. So when the brain suffers a stroke or a traumatic injury, neurons are deprived of oxygen for a prolonged period of time and they die off and they do not regenerate. So the damage isn't always limited to directly affected neurons. So when we were talking about the glial cells, I hit on this a little bit, but excitotoxicity is cell death that's caused by overexcitation of neurons, and that may add more damage. So injuries that damage or sever axons cause degeneration, but they might not result in cell death. Some neurons have the ability to regenerate their axon, and we'll talk about the factors in that. Injury to the axon or injury that destroys the cell body of a neuron leads to cell death. So this is a little chart from the book. Ischemia, which is lack of oxygenated blood, can lead to glutamate release. Glutamate release can activate calcium channels and release of internal calcium stores, which can cause increased glycolysis, producing lactic acid, leading to cell injury and death. It can also cause increased intracellular water, leading to cell swelling, leading to cell injury and death. And it could also activate protein enzymes, which create more oxygen-free radicals, which lead to cell injury and death. So unfortunately, all roads in ischemia could potentially lead to cell injury and death. So when you have an axon injury, the same processes that follow a peripheral axonal injury also occur during a spinal cord injury. Damage evolves hours and days following the initial injury due to a cascade of cellular events. So that chart we had on the last slide, that was a cascade of cellular events. The extent of deficits depends on the degree of damage to white fiber tracts in the spinal cord and the vertebral level of the injury. So you can have injury that results in cell death. You can have injury that just results in a decrease of stimulation to a particular neuronal area, and that decrease in stimulation is what causes the cell to die off. So when an axon in the peripheral nervous system or central nervous system is severed, the part connected to the cell body is referred to as the proximal segment, and the part isolated from the cell body is called the distal segment. So the extent of the injury has to do with the effects to the different segments of the neuron. So in the periphery, axon severance injuries frequently occur. So they could happen because you had surgery in a particular area and they had to sever the axon to do the surgical incision. They may be severed in injuries from sharp objects or an extreme stretch that pulls the axon apart. So growth of a new branch of an intact axon or regrowth of a damaged axon is called sprouting. So you can actually get a, in the picture A before the injury, you have two different axons synapsing with two different cells. You get, after the death of one of the presynaptic neurons, you get sprouting from the other one to basically take over its function. The peripheral axon sprouting can cause problems when you innervate an inappropriate target. Because remember, the action potential running down the cell, we don't know what the effect is. It has to do with what pathway it takes. So if you get that collateral sprouting, it can actually change the pathway and change the function of that nerve. So you can get different differences in sensation and differences in effects from that axonal sprouting. So in the central nervous system, usually in spinal cord injury or traumatic brain injury, you can get axonal tearing and breakage, but most of the damage evolves hours and days following initial injury because you get that cascade of cellular events. Functional axon regeneration does not occur in central nervous system axons. So there is a central nervous system growth inhibitor hormone that's called NOGO, and there are other growth inhibitors in the central nervous system. So there's currently research to block the effects of NOGO and other growth inhibitors to help spur recovery in central nervous system injuries. Stem cells can also provide another method of treating white matter injuries and demyelinating diseases such as MS. So there's kind of a lot of research going on, but there are not any treatments that are currently in place. So in cellular recovery from injury, injuries that damage or sever axons cause degeneration but might not result in cell death. But when a neuron dies, the nervous system promotes recovery by altering specific synapses. So following a central nervous system injury, the body uses several mechanisms to overcome damage. A lot of the same mechanisms responsible for brain plasticity during learning are involved in a recovery period following a neuronal injury. So you could have a situation where a previously masked synapse is unmasked after loss of some presynaptic terminals. So it unmasks other ones in order to recover synaptic effectiveness from an injury. So the idea is we want to recover synaptic effectiveness, we want to decrease hypersensitivity, and unmask those silence synapses. So the way that most of the recovery after a stroke comes in is through functional reorganization of the cerebral cortex. In other words, areas that previously did not do a certain function take over doing that function. So researchers can map functional areas of the cerebral cortex by recording neuron activity in response to sensory stimulation or during active muscle contractions. So cortical maps can be modified by sensory input, experience learning, and brain injury. So reorganization can take years. So a lot of times they'll talk about recovery after a CVA being only in the first few months of recovery. That's not true in terms of neuroplasticity. A lot of your functional recovery is going to happen in those first few months, but then you have to continue doing activities to get that functional reorganization of the cerebral cortex. So reorganization after a nerve injury can also be a factor in some chronic pain syndromes, and we'll talk about that in the chronic pain chapter. So the idea of constraint therapy and some of the other therapies after CVA have a lot to do with functional reorganization of the cerebral cortex. So the idea is that there are areas where cells died because of that ischemia, and whatever function that particular area did before, another area is going to have to take over that function. However, in order to get that functional reorganization, you actually have to try to perform that function. You have to recover functionally in order to get the reorganization of the cerebral cortex. So there can be activity-related changes in neurotransmitter release. So repeated stimulation of somatosensory pathways can cause increases in inhibitory neurotransmitters, decreasing the sensory cortex response to overstimulation. And understimulation can have the opposite effect, causing the cortex to be more responsive to weak sensory inputs. So There have been preliminary clinical trials that show promising therapeutic benefits to treat various conditions, including stroke, Alzheimer's, Parkinson's, Huntington's, and ALS. Some of the recent Parkinson's research shows that vigorous activity, so that's kind of repeated stimulation, can actually better use the neural substrate that you have left. Vigorous activity in Parkinson's actually causes dopamine to persist longer in the synaptic cleft. It doesn't get taken up as quickly, retaken up. And so you can, even though you have a diminished amount of dopamine, you can get better use of the dopamine that you do have. So activity-related neuroplasticity is a big thing in rehab these days. And so if we can use exercise as medicine to stimulate neurotransmitter production, that is a very powerful thing. So stem cells are involved both in brain remodeling following neurological injury and in development of new neural circuits. So neural precursor cells migrate towards the ischemic area after a stroke, and many cells that arrive near the ischemic area don't survive, possibly as a result of that inflammation or that excitotoxicity that we talked about a couple slides ago. So neurogenesis is an exciting avenue of discovery of novel therapies to treat brain injury or disease. So there's still stem cell activity in the brain, even with a mature brain, but what the areas of research that are going on now is how do you keep those precursor cells from getting killed near the ischemic area as a result of inflammation, and how do you get them to develop into the neural pathways that you want. So we can have a lot of effects on plasticity with the kind of rehab that we do. The recovery of neuronal function after brain injury is influenced by the intensity of rehab and the timing of the rehab relative to the injury. So early rehabilitation is necessary for improved outcomes. Prolonged lack of active movement following cortical injury may lead to subsequent loss of function in adjacent undamaged region of the brain. So this graphic from the book actually is showing what happens after lesion if the affected limb is casted, so it can't move. We actually get more brain death and damage in the first couple weeks if we don't do functional movement with the affected limb. So there are specific types of rehabilitation that are effective during the chronic phase post-stroke. So the functional magnetic imaging and the magnetic brain stimulus that they were talking about earlier show that task-specific training, as opposed to other types of traditional stroke rehabilitation, produce long-lasting cortical reorganization in the brain areas activated. So that's what I was talking about earlier, where if you don't do a certain activities, your cerebral cortex is not going to reorganize to learn to do that activity again. So even during the chronic stage post-stroke, plasticity can occur with rehabilitation even after months or years following neurological injury. So task-specific training induces more regular patterns of brain activation compared with general use training of the upper extremity in individuals with stroke. So you want to train people in functional activities, things that they really do with the affected limbs. So there are specific excessively vigorous rehabilitation of motor function too soon after the injury can be counterproductive. You can actually cause more damage in that area if it's, right after the stroke. But there's an interesting part in the book talking about constraint-induced movement, and in the brain that changes itself, they talk about constraint therapy. So with constraint-induced movement, they actually constrain the unaffected limb, and they make you use the affected limb in order to rebuild new pathways. So that's a pretty interesting area of rehabilitation, constraint-induced therapy. So the limb that's constrained is the unaffected limb, or the less affected limb, and so it forces you basically to use the affected limb for functional activities.